Today morning we are starting with a session from Professor Diego De Leo talking about youth that attempted suicide, and he will be talking about what is best doing for them. And I hope that, with yesterday's lectures, we opened up the floor to think about different risk factors, different epidemiological trends, different risk groups that we need to pay attention. And therefore, we gave our Professor Diego De Leo a very difficult task, actually, to talk about those that are already that felt so much pain and distress that already attempted suicide. I'm sure that most of you know Professor Diego De Leo, but anyway, let me introduce him formally. He's the head of our Slovene Center for Suicide Research. But not only that, he is internationally one of the most renowned scholar in this field. He has led many international projects, made a big difference in terms of definitions of suicide, in terms of culture and suicide, geropsychiatry, and so on, and has more than 420 peer-reviewed articles and 180 book chapters to read. So it's always a pleasure and an honor to work with him, to listen to his lectures, his wisdom. And maybe that would be enough for the introduction, Diego. We managed to put your slides on. So with that, I would be happy if you take the floor and share your thoughts on the topic.
Thank you, Vita, and thank you all for joining us today. I have to start with an apology because yesterday I was taken by a kind of family issue which was very urgent, and I couldn't attend as planned before. So I was kindly substituted by my friend Vita and Usha, and I'm sure that they did a big job for you. Now, I have heard the talk by Professor Anne John, and I didn't want to bother you by repeating a few things, but I rephrased a bit my presentation, and please, I need Vanya helping going ahead with the slides because I cannot maneuver them from here strangely today. Um, so, Vanya, can you go on? Yes, I don't have anything to confess you regarding any economic financial interest in this talk. Ahead, please, Vanya. So, first of all, commencing this talk, it's important to clarify what we are talking about. As usual, we need to provide in our research a clear-cut definition of what is meant in the course of our research. And I would say that the topic we are talking about is flooded by a bit of confusion. And terminology is certainly important because if we wanted to study clearly a phenomenon, we have equally clearly to define what is the phenomenon. And if you go through the international literature, still today, you have a variety of definition of what we are trying to delineate today. Sorry. In the past, WHO endorsed the definition of parasuicide, for example. It was an idea moved by Norman Kreitman and Stephen Platt. They were concerned with the fact that it is impossible to clarify the intention to die, and we needed a definition that overcome this problem, was wide enough to encompass everything. And so parasuicide was the chosen definition by a large multi-site study on parasuicide in Europe. Very large because it included at the end more than 40 centers. Really an historical and important research. Then a usual definition is suicide attempt, self-harm, but before self-harm, UK insisted on deliberate self-harm, for example, and adding a few confusion to that, and then self-injury, suicidal behavior. But the confusion originates what we can define as unsatisfactory. The use of parasuicide now is neglected because parasuicide is basically mimicking suicidal behavior. Not all are Latinist around the world, so the use of para could be very confusing for those not familiar with the Latin language. So at the end, it may be understood as mimicking suicidal behavior. Then we use stigmatizing terms like admitted, committed, successful, things that couldn't enter the domain of criminology and couldn't enter any type of judgment. And so we need to certainly avoid those terms. Self-harm in itself is not a perfect terminology. Self-harm, it doesn't involve, for example, desiring to die. You just self-harm yourself, but is not stated if there is any intention to die or not. Self-injury, on the other hand, excludes any not visible, not tangible alteration at the anatomical level. Self-directed violence was the successful term used in the first WHO report on suicide, which was not actually a report on suicide, but it opened the gate to the possibility of organizing the World Suicide Prevention Day. The reason was that self-directed violence was the term used by me and José Bertolotte, who was then the head of the suicide prevention section, and to include this term, self-directed violence, on a report that was called Violence. And the report Violence was published in 2002 and presented at the court of King Albert in Brussels, and it was followed by an immense number of people, including 22 Nobel graduates. And the head of WHO at that time was a lady, a Norwegian lady who had lost a son to suicide. And when she heard that I hoped for the field of suicidology, that there was a day dedicated to the problem, she said, well, this is a good idea, let's do it. And we started in 2003 for the first time the World Suicide Prevention Day. Suicidal behavior, it's an over-encompassing terms, and suicide-related behavior could be interchangeable with this term. Ahead, please. So there were Vanya, you are obliged by the system to follow me, and I'm sorry for that, but you need to move. So parasuicide was then excluded because it was considered initially a subcategory of attempted suicide, or they were at the end even exclusive mutually. So it was very unclear and creating confusion. Next one. And what came out the study, the WHO multi-center study on suicidal behavior, was this definition, which was trying to be an encompassing definition. Non-fatal suicidal behavior, which can be with or without injuries, as a non-habitual act with a non-fatal outcome that the individual expecting or taking the risk to die or to inflict bodily harm initiated and carried out with the purpose of bringing about wanted changes, wanted desired changes. And this was the schema that WHO brought ahead at that time, subdividing the possibility that the subject remain alive or deceased, and noticing that self-initiated suicidal behavior could also bring to an accidental death. So there was no intention to die, but by accident the person may also die. And frequently, the case of Sylvia Plath, the American poet, was brought ahead to justify this possibility. Next one. I have to go slightly differently from what and John presented yesterday, um, and try to bring your attention to the main characteristics of suicidal behavior in youth, in order to understand better what sort of intervention can actually be performed trying to help these individuals. Next one. Um, it's important to pay a lot of attention to any activity definable as suicidal behavior, because these individuals are at risk of subsequent suicidal behavior, but also of fatal suicidal behavior, particularly in the first month and within the first year from the index episode. Next one. The people with suicidal behavior, Keith Houghton, with this English self-harm behavior study, demonstrated is that these people are 30 times more prone to, compared to the general population, to present a risk of repetition and of death. Next one. And the risk is not equally distributed between sexes. Females make more attempts, and males have higher mortality. Hospital presentations are particularly elevated in terms of numbers among girls in mid-adolescence, around 14, 15 years. If the method of suicidal behavior was a violent one, prognosis is the worst. However, something that needs to be kept in mind very clearly is that the first attempt or the first episode of suicidal behavior can be non-violent, But this doesn't mean that there is no risk for mortality. People change their method of suicide, and usually they started with a non-violent one, and then they choose asphyxiation, hanging, as method to die by suicide. Very good, Vanya. You're improving. You're synchronizing with me. Excellent. So, um, in a population, adolescent suicide attempts are able to predict future subsequent attempt, and these are normally accompanied by an increased level of anxiety. And later on, there is also a coupling with depression often. However, we need to be aware that the situation is more complicated, is more complex than what we consider, because having a subsequent attempt is a kind of an index for a liability, a pre-existing liability, and is not showing any independency of the act. So it's not coming out of the blue, the act, but there is something that preceded and should be scrutinized in a better way. I mentioned the study by Keith Houghton and assistants to him, other collaborators, and the recruit number was more than 9,000. And up to 2015, there were 124 people who died within the study, and 55 of them were caused by suicide. So the risk, as I mentioned before, is 30 times that of the general population of comparable age. So we need to pay attention to what could be. This happened in England, but the next one shows Canada for a similar study. Vanya, you were synchronized. Yes. And here the numbers are even bigger, 20,000. And 1 year, just 1 year, showed a risk 32 times the one of matched peers. So more risk in Canada compared to England, but equally high risk of dying by suicide. Here the cohort is even bigger. It's New South Wales, is Australia. The number of individuals grows in age up to 29, and the number of events is astonishing, with a number of suicide equally important. This number drops after 5 years, drops considerably. So it remains quite high the first year, but then longitudinally it drops. You will see later that at 10 years distance, we have probably 5 or up maximum 10, 7 cases per 100 that die by suicide. And the study, the cohort in France found equally a high level of repetition with a mortality quite similar to the other studies, probably a bit lower for 1 year, but this points out to differences that may be based on several different factors, not only culture in the widest possible term, but also to assistance, organization, family networks, friends, etc. Many components may justify the differences. Go ahead. So, if we want to consider modifiers and differences that should be kept in mind, we basically have to consider sex, as we have seen, but also age, method, prior history, and presence of psychiatric conditions. We have seen also in Piedmont, northern Italy, that a Croatian lady, Emina Mihanovic, is the head of a longitudinal study, not a big one, but pretty long, 11 years long, that showed number which are double in females compared to males. The more sorry, my health is not at the best, so my apologies. But anyway, you have seen that the mortality is bigger, much bigger in males than in females. And we have to remember, of course, that the ratio in the Western world is at least 3 to 1 in general. It is similar to that, but a little smaller entity when subjects are younger. But the ratio with growing age parallels at least 3 to 1, 3 men for 1 woman. And the idea that age changes because the older the subject, the higher the probability that mortality is there. So there are also differences. If I compare France to England, hospital admissions concern younger individuals in France and 2 years older in England. But we have to keep in mind that these also it's related to the network of a point of assistance, availability of GPs, frequency of contacts with GPs, and availability and timely availability of GPs, all confounders in this type of investigation. Next one. And also clearly, as I preceded you with a statement like that, don't rely on non-violence method. A non-violent method, an overdosing with medication, for example, even paracetamol or aspirin, may be followed by a lethal or more lethal method. So we have to keep in mind that the method may change and the capability of sustaining pain, being able to familiarize with the pain of a method and the dangers involved with the method is favoring the choice of a more lethal method. Next one. And also psychiatry is in the picture, of course. If you have a psychiatric condition, the possibility of feeling that life is difficult, that people look at you in a different manner, that the stigma is there, that your life becomes more complicated, that the opportunity, the probability of a choice in the direction of suicidal behavior becomes more probable. Um, Actually, in the Italian sample guided by Mihanovic, there were even 90% of suicide attempters who had a psychiatric diagnosis. But please notice that these people were recruited only in hospitals. So the number of hospitally attended person, the hospitalized or the people going to an emergency department is much smaller than the number of attempters in the community. So these are a selected group of individuals. So it's much higher the probability that there is something tangible in the psychiatric direction to be detected in them. Yeah, another factor that seldom is considered in research is that the family cohesion can be a factor of difference because you make a suicide attempt in a family that neglects you, then the probability of reattempting is much higher, of course. And but this factor is rarely considered in research. We'll come to this issue later. So higher severity, higher lethality. So people are subdividable in different groups on the basis of the violence, lethality of their attempt. Clearly, it's very difficult to disentangle the intention of people because, as the European multi-center study identified, there could be up to 14 different intentions behind suicidal behavior. Not only wanting to die, clearly, or wanting to sleep, or wanting to be away, or wanting to demonstrate that there was a crisis, or wanting to know if the other people loved you, or wanting to discern how many people are really interested on you. So there are, for example, such a big number of intention behind the hat that clearly all these intention, even once identified, never exclude the possibility that people are pretending something, they are inventing something, or denying something. So you deal with people that may tell you, well, I didn't mean to do anything terrible, it was just an accident. Or people dramatizing their intention and telling you that they wanted to die. Next one. So, just to summarize, that the danger is particularly elevated in the first month, but also the first year aggregates, then it dilutes a bit between 1 and 3 years, but it remains high just in terms of suicidal reattempts, but also other causes of mortality for longer time. So these people are at risk because they usually don't care about themselves, self neglect, abandon trivial occupations, or any other factor that may be reconducive to a life without too much intention for well being. Next one. Now, some of my experiences, these are from Australia, where at that time, at that historical time, self cutting became a major problem and in some way influenced the attempt, the American attempt to introducing the DSM system, the non suicidal self injury diagnosis, which remain always out despite the intention of many people. David Sheffer, for example, was the introducer of this diagnosis, but Jennifer Mullenkamp and many other insisted on having a diagnosis that could stigmatize millions of young individuals with a psychiatric diagnosis. Next one. This was a very lucky study in the course of the WHO Supremist study. We made a very large community survey in Australia. Next one. And these shown clearly that death thoughts, suicide ideation, and suicide attempt were much higher than any other age group in younger individuals. So, and this was run also as an observation with another Slovenian lady, Jerneja Sveticic. And Jerneja and myself brought to people showing history of suicide attempt these two graphs just to clarify and to test the hypothesis that was vigent at that time, that suicidal behavior is the byproduct of a continuum. And as a clinician, I never believed in this continuum hypothesis, but we wanted to give a scientific basis to this hypothesis. So we showed these two graphs to people, and we asked them which one of the two identifies yourself. And as the next one shows, Vanya, the majority of people say that there is no continuum hypothesis in their suicidality. There are people in time in which they feel happy or reasonably satisfied, engaged with life. Then they drop, they go down, and then they go up again. So it's a fluctuating way in which, in the majority of people, suicidality occurs. Clearly, there is more continuity in those who are chronically depressed. There, you can imagine to find this continuum hypothesis. And if you go to the community, not to hospital settings, to the community, you can see that the number of people with a history of suicide attempt is much bigger than what reported by hospital setting. It's 23 to 1, actually. So much larger. Next. With a prevalence of females in a ratio 2 to 1. So the reverse of what happened in suicide. So a suicide paradox exists embedded to sex. And this is what I mentioned before, the WHO Supremist study, which means I'm not talking about a beautiful lady, a miss, but I'm talking about a multi-site intervention study on suicide. This means suicide prevention, miss. This was the title of the study. And it was strategically important because it involved countries that never collaborated before. So China, for example, Iran, Vietnam were the first activity in collaboration with other nations. And we imagine that in these countries, the expression of suicide attempt could have been different. Next one. As you can see, we also imagine in a certain level of detail what could have been the variables making the difference. For example, not only the density of the population, not only the religion, not only the marital status, the literacy degree, the education, the level of employment, being before or below the poverty line, having psychiatrists to be able to consult, and having emergency services. China, Iran, and Sri Lanka at that time, in the location chosen for the study, had no emergency departments. So suicide rates and suicide attempt rate needs to be uh, matched with these variables to provide a real interpretation of result. Next one. And to understand who are the people that die by suicide and which are the methods. Cell poisoning by pesticides was very common because countries like the one in China and in India were incredibly common in terms of usage of pesticides. And in these cases, in these scenarios, the destiny of suicide attempters may be very different on the basis of the variables that I previously mentioned. Next one, Vanya. So, for example, as you can see, ingestion of pesticides, it's very, very frequent. And this overdosing method, it's the most popular, but due to the peculiarity of the places, clearly, in a country like Italy or Slovenia or England, the use of pesticide is not that common because agriculture is not a major industry in those countries. So the access to this type of poison is not that frequent. Next one. And okay, next one again. Another study that concerned only Europe was the case study. And since I was quite relevant in the area of suicide, it was Europe more Australia, as seen in the next slide. And these are the differences in the prevalence of the self harm in a community sample. You can see very clearly that the prevalence of female is without any contestation in all these countries. There are a few differences in the frequency when it happened, but uh, not so significant. Next one. What was a relevant apart method? Go to the next one. This was pretty relevant. So these were a few elements justifying the attempt in these young people. So the most important, most common trait was I wanted to get relief from a terrible state of mind. This was the principal cause to attempt suicide. Then there was I wanted to die, which was quite robust in terms of frequency. But also, I want to punish myself. I wanted to show how desperate I was feeling. I wanted to see if there is anyone out there that really loves me. I wanted to get my own back on someone. I want to obtain attention. I want to terrify someone with my behavior. So, see how many different, these are not the 14 that I mentioned before, but these are relevant behind the intention of these people. Now, go finally to the intervention. The big study, by definition, is the WHO Supreme study. So, brief intervention and contact is big. Basically, we had countries with no services, but we had countries with nuns, with volunteers, with people. And these people may, in our intention, in basically in my idea, were able to maybe provide some follow-up to people. And in fact, this study was a randomized control study, not double blind, of course, but randomized control study. And people were attributed, nearly 1,000 people per arm, the sum of all centers, were attributed to either treatment as usual, tau, or treatment as usual plus BIC. BIC was an intervention carried out in several different manners, in person, or by telephone, or by letter. And it was as long as 18 months. So there was an important difference. Next one, Vanya. Because people receiving a follow-up and not a treatment as usual simply had a significant, a very significant level of less mortality during the period considered than those receiving tau, which means that if you pay attention, if you let the people feeling that they are not alone, that there is someone or something interested in them, someone able to follow them for ages, someone able to ring them 3 times at least, if they not answering at the first time, but with 3 attempts, then those people were the one able to obtain the biggest advantage. Next one. In more recent time, we have seen that has not changed much the mortality level. At 5 years, it's still very high, and 7 people out of 10 maybe were at 10 years big. Next. People having multiple attempts, people going to hospital because of each attempt, people with greater severity of symptoms, my apologies, were the one at highest risk to die by suicide. Next. And the problem with following these people, making the right therapy to these people, is still a major problem. Well, we have tried nearly everything. Um, we have tried all sorts of psychotherapies. Marshall Linen invented dialectical behavioral therapy. Marsha is herself a borderline personality carrier, and Marsha had created this for borderline personality disordered people. Why for them? Because they are more impulsive, because they can be more violent, because they don't think, but they decide immediately what to show, because they probably show a big need of attention, because they have a variety of features that may render particularly problematic the approach to them. Next one. So we have tried to summarize a few of the interventions that were presented recently and see that Some study is very disappointing. This is one of the disappointing one. They compared several types of intervention in meta-analytic reviews, and they saw no convincing results showing the superiority of a method towards the other, and not even studies able to show that there is a decrease of attempt or reattempts at 1 year distance. Next one. So there are also studies that criticize positive study because they say the risk of bias is out there. In many of these studies, there is some mistakes in planning of the study or some overinterpretation of results. Next one. And this is a very quoted study. David Cottrell is a person that has dedicated a lot of his career to the study of intervention on suicide attempters. And well, it's not particularly in favor of a method over the other. It was someone being able to follow quite carefully people, and there is some inclination toward dialectical behavioral therapy over the other. But there are also studies made with cognitive behavioral therapy, maybe smaller studies showing some result. Next one. The problem is that you have to give the people the sense and the conviction that you're actually following them very clearly. And next one, I see my time expiring. Next one again, it's the success of following or keeping followed individuals, it's very important. The minimum achievement can be obtained by at least one follow-up after the attempt. Only one session, even after the attempt, shows superiority compared to the other. So big, especially if continued, can be a very important issue. Let's go to the difficulties for concluding. Yes, this one. Thank you. Open the first one. What are the gaps? What are the difficulties in research? Intention is not always cleanly classified. Psychosocial exposure are not completely observed. And we cannot generalize results if not to those attempting suicide at being seen in an emergency department or being hospitalized. But we shouldn't mix up the two. And then we need to pay attention to attrition, to history of previous attempt, and to face attrition. Next one. And nobody really takes care if there are physical sequelae of suicide attempt. We need to control the many moderators that are there. ED discharges, medical admission, psychiatric therapies, or even psychiatric apnation, besides the problem with definition and outcome. So a lot of things. But so what I want to say that there are many difficulties in this. Go to the next one. What I want to push the attention of the individuals is toward defining and control all variables, defining and control definition, defining controlled environment, defining and control the settings, defining and control the history, also the medical condition, not only of the psychiatric condition. Everything can make the difference. To conclude, is just to remind you that there is even a commission operating on the case of Kurt Cobain, because this is his farewell letter, which has been published many times. And in February this year, there was a commission doubting that it was a suicide, but could have been a homicide. So it's a kind of, theoretically at least, an open case. I believe it was a suicide, but that's my personal opinion. And the following one are just to show you how are the farewell letters of people, young people who died by suicide. This is an Italian case. Next one is also an Italian case. And this is an Australian case. And an Australian, my goodness, I'm short of time. Vanya, you're right. And um, okay, okay. Thank you for your attention. Thank you, Vanya, for your patience, and I'm open to answer.
Thank you, Diego, for this really insightful presentation and the deepening of our understanding of what's happening in the most serious cases, so to say. We could easily listen further, but we have a schedule that is running, and that's, I think, the reason behind the push. But it was, I'm sorry that we had to skip actually some of the slides. You already have a few questions, and I saw that they're already coming in. And I will read you the first one from our colleague Nina Krochne, who is thanking, first of all, for the amazing talk. Now, she's saying, we know that adverse childhood experiences are important risk factor for suicide. What is your view on how these experiences, particularly exposure to violence, shape the trajectory from suicidal ideation to attempt or even suicide in adolescence? Should clinicians pay attention to something in particular when dealing with such adolescents? So, youth that is experiencing violence in particular.
Well, violence is something that you learn. Violence is something that you imitate. Violence is something that can be transmitted, and people are not educated by books when they are young, but they are educated by seeing their parents, how they behave. So they uh, consider normalizing the use of something that they have seen in their family. So, as usual, we need to teach parents how to become good parents, and what to do with their children, how to behave with their children. And this is the most real and most effective type of intervention to avoid violence and perpetration of any uh, domestic, sexual, or physical violence in any other respect. And something like abuse, physical, psychological, sexual, it's very frequently present in the history of these individuals. So the answer is there, basically.
Thank you. There is anonymous attendee that is actually following up on the topic of families. Again, saying, first of all, thank you for this excellent lecture, Professor De Leo. You mentioned family cohesion as an important factor, but without extensive scientific evidence. To what extent are family factors considered in therapeutic approaches to youth with suicide attempts? What else should be done to understand these factors better? So again, it seems like the family are kind of a left aside, maybe too much.
Well, as I said, this is a variable that is often neglected in the research to study why people are repeating suicidal behavior. What is the role of the family after a suicide attempt? Are they close to the attempter, to their son or daughter who attempted, or family are neglecting what has happened or minimizing what has happened or consider it just a stupid act that should never be repeated, as many families says. So the behavior of the family, the vicinity of the family, the attempt to understand what has happened is of crucial importance in the follow-up of people and in their eventual repetition. As I said in our research, in research in general, we should never neglect this type of research and of this type of behavior because it is a variable that really may make the difference.
Hmm. Exactly, yes. Now, sometimes we don't have so much control over the families, but maybe we have what our interventions in the mental health field, interventions like BITS that you have mentioned. Do you have any maybe insights on the recent brief interventions that are happening for the young people? For example, are they still done with the calls, or are they done with the text messages or with some apps? Is it working in the same way if we make it through an app or through a short text message, or if the phone calls are still, I mean, I would imagine, making a personal contact makes it a difference, but what is the role of technology here, so to say?
Yes, I have some initial data because here in Padua we are doing such an exercise. Nicola Meda, that you have met probably in some congress, is the leader of this research. Now, let's reason together. At the beginning of the history of app, receiving a message was very welcome because it was new. And it has validity then because people were excited by feeling themselves as followed by someone. But now these messages are automatized, and so there is no value in them. You need to follow the people personally.
Mm.
This adds value.
Mm. Yes, yes, I imagine it that will be the outcome. Diego, so many questions came in while we were talking, so let's consider at least a few. So uh, there is a anonymous attendee thanking again for the inspiring lecture, and he's saying, or she, I'm curious about your thoughts on the life promise technique for adolescents in suicidal distress. So having them promise the therapist that they won't take their lives, perhaps even sign an agreement. So it's more like a therapeutical technique that you have. Do you think it's working or it's not working, or what would be your thoughts on that?
Look, to be very straight and very honest, as my age and my character suggest, in dealing with suicidal patient, there should be a selection of professional. Selection of professionals in the sense that you have to be passionate for what you are doing. You have to transfer to the people the net feeling that you are taking care of them. This is the most important message. But if you are simply a professional, simply acting in a technical way, simply acting in a polite but professional, the rate of your success, in my view, would be minimum.
Mm.
So that's why I'm insisting of selection. You can deal with many other diseases and conditions, but in suicidal behavior, you need to be a kind of a special person, a
Mm.
kind of a special professional with a heart for people with this level of suffering.
Yeah, so the
Sorry
relationship.
for my answer is probably discouraging people, but this is what I think.
Yeah, no, but it relates again to the relationships that you build in a way. So it's again, either you do bits or you do, the therapy in a way. If you have this automatic things, just, that probably won't solve people's
No.
problems or lives, or make them go through their suffering, or motivate them to continue. Yeah. Now, maybe we don't have too much time, but I just wanted to dedicate maybe time for one or two questions more. There is someone else that is again thanking you for sharing the valuable knowledge and experiences. Here she's saying, I would like to know your perspective on the digital interventions for the prevention of self-harm and suicide. As per your experience and knowledge, would you think that the help-seeking behavior of the youth can be shaped by digital interventions and i.e. while addressing the stigma? So we talked yesterday that there might be some beneficial effects. That's what I'm putting. I mean, we addressed this issue of relationships, but again, probably not everybody has this opportunity to have the relationship. Is there some beneficial potential in the artificial intelligence and
Well,
technology?
I think that surely there is a beneficial impact for those people who don't trust anymore their professionals because they were mistreated by them and they didn't receive the help that they hoped for. So for them, clearly, artificial intelligence or digital mental health could be a way, if not the only way, to obtain some advantage. You know, in the clinical practice, you may receive many people who are very disappointed with the system, very disappointed with the help they received so far, which was not really help, but it was mistrust, disillusionment, disappointment. And having someone seen as perfect and neutral, like artificial intelligence, there are people that already said, I would prefer a session with Chat GPT Plus than with a doctor. So at least Chat GPT knows more than a doctor and is neutral. So he's not stigmatizing, he's not punishing me, he's treating me fairly.
Yes, yes. So yeah, again, pluses that could be, yeah,
Yeah.
considered as valuable, and also of course, yeah. Maybe just last one, Lauren, who's a very active participant here, and I'm very thankful for that, is saying that Deaton in his book used the term death of despair, pulling together suicide and other causes of death, such as overdose. So, just a terminology related question. What would be your take on this term? So, death of despair, suicide and other causes of death. Would you say
Not sure
it's
I understood the question. Can I see it written?
so it's the first one that is in the Q&A session, if you are able to open it.
Death of despair, pulling together suicide and other cases of death as overdose. Well, I'm not familiar with this book, but certainly death of despair could be an compassing method, so terminology, and certainly nobody dies happy. People dies in despair. This doesn't go to be confused with depressed, with a psychiatric condition. So you can have no hope for the future, so literally be despaired. And this can be a condition that can be clustered with deliberate overdosing, for example, when you cannot deal anymore with life and your way of living. And yes, why not? We can pay attention to that. Maybe it's also a term not stigmatizing and being freer to use.
More open, yeah. And the last one, Diego, really last one. Thank
Yeah.
you for the talk. In the statistics of the data that women are more likely to reattempt suicide is the fact that men are more likely to die already after the first attempt already counted in. So,
Well, yes, in the sense that I believe that the term failed suicide was born in answering this very question. Clearly, failed suicide is very malish, because you should attempt and be successful, but both terms are terrible, and so we try to avoid use them. But certainly, a real man, and this is the masculine culture, a real man doesn't fail. And a real man doesn't reattempt in a failed way, must be successful. So, yes, there is some true in that.
and with that, I think, Diego, we managed to kind of also address more or less all the questions. I think I had to dismiss only one for the time reasons. And I want to thank you for sharing your thoughts, your insights, and the experiences that you have gained throughout the years. So it was really insightful, and we are all thankful for that. Thank you. Thank you again. You
Thank
can
you
see
all.
people thanking you. And I suggest that we take a little bit less than 20 minutes of the break, and we'll be back with a talk supporting how to support teenagers bereaved by suicide. So we'll go to the different points of view because we haven't addressed actually the post-vention and the bereavement yet this year. So thank you all, and we see you in 18 minutes.